guys, today we are going to discuss FMGE recall, the questions which recently came into FMGE exam, and let's see, start. Okay, first question is, in a patient presenting with acute onset chest pain, we found low BP, engorged neck veins and poorly audible heart sounds. What has happened? Okay, what are we seeing in this X-ray? We are seeing a huge heart and of this shape, okay, and there is sudden onset, it is sudden onset, and there is low blood pressure. Now let's look at these choices. Constrictive pericarditis is not usually sudden onset and the blood pressure is not very low. The heart sounds may be poorly audible because of presence of pericardial effusion, okay. This is cardiac tamponade, guys, where there is sudden accumulation of lot of fluid in pericardium which will compress and obstruct the heart and patient will go into shock. It is a medical emergency, cardiac tamponade. Cardiomyopathy is a very poor choice. Cardiomyopathy is a very broad term. It can be restrictive, it can be dilated, it can be ischemic, right. Then there is right heart failure also is a very poor choice. Right heart failure means what? Like RV, there is maybe RV MI, there may be RV dysfunction for some reason, obstruction, which can present like this, but it will not cause such big size heart. So the answer is B, cardiac tamponade, okay. So what happens is during cardiac tamponade there is obstructive shock. You know what is obstructive shock? When there is shock due to flow of the major blood vessels or heart itself. So the conditions which cause obstructive shock are acute massive PE, in which there is obstruction to the right ventricle, severe tension pneumo or cardiac tamponade. We have to immediately put needle and drain it, otherwise this patient is going to die, and the answer to this question is B, obstructive shock, okay. A patient with recurrent syncopal attacks in angina, he is diagnosed to have aortic stenosis. What are the features of aortic stenosis? He has given you angina and syncopal attacks. So it is basically three things that aortic stenosis patient presents with: angina, syncope and dyspnea, okay. These are the main three features. And so when there is, suppose aortic stenosis here from the LV, so there is post-stenotic dilatation usually like this in aortic stenosis. So what we get is post-stenotic dilatation. Dilated descending aorta can occur with aneurysm or coarctation. If there is coarctation, so of at the level of left subclavian, then we will get dilated descending aorta, or before that, if before the coarctation, before the coarcted segment. Widening of aortic knuckle occurs in all high output states like PDA, like aortic regurgitation. They can cause widening of aortic knuckle, whereas dilated aortic valve is a feature of aortic regurgitation, okay. So the answer is A. In a patient suffering from lymphoma or breast cancer, which of the following renal disorder is associated? Okay, let me tell you about all of these. FSGS is one of the severe type of nephrotic syndrome. It usually presents as nephrotic syndrome, and the common causes are HIV, heroin abuse, hypertension. Reflux nephropathy is important. MPGN is two types, type 1 and 2. Type 1 is common with usually hepatitis C and cryo, and type 2 is seen with HBV, HCV, malaria, leprosy. Whereas membranous nephropathy is the most common cause of nephrotic syndrome in adult population. It is seen with malignancies, mainly solid organ malignancies, and also with connective tissue disease like RA, SLE, scleroderma, and also with hepatitis B, C, malaria, etc. Okay. Renal artery stenosis has nothing to do with these. So, since our patient is having malignancy, right, the answer is C, membranous nephropathy. There is very high risk of thrombotic complications in patients of membranous nephropathy, like renal vein thrombosis. In children, it is mainly due to minimal change disease, and in adults, membranous nephropathy. Okay. This is an easy question. What we are seeing here is a straight line on this chest X-ray. Identify. See, pleural effusion, what do we get? We get blunting of CP angle, and we will get like this. CP angle will become like this, right? Pericardial effusion, we get money bag appearance. The heart will become like this. Pneumothorax, there will be black area here with absent bronchovascular markings. This is hydropneumothorax, where we get horizontal air fluid level. The air is up and the fluid comes down, and there is a straight line like this. So this is classical of hydropneumothorax. Usually hydropneumothorax is iatrogenic, can occur during aspiration of effusion, ruptured lung abscess. Okay, these are the causes. So the answer is D, hydropneumothorax. Okay. An elderly patient, this irregularly controlled hypertension, and this is a CT. Okay, guys, what we are seeing here is a bleed. In CT scan, the dark black, more black than the normal, is infarct, and white when we see is bleed. So this is intracranial hemorrhage, right? And where we are seeing it in the region of basal ganglia or putamen. Okay, when I classify stroke, 85% of strokes are due to thrombosis or basically infarct, out of which 25% are thrombosis and 75% embolism, and only 15% are bleed. And the bleed also, intraparenchymal or intracerebral hemorrhage is most common, followed by subdural, epidural and subarachnoid, subdural, epidural and subarachnoid. Okay, so uncontrolled hypertension will lead to intraparenchymal hemorrhage, for which for hypertensive bleed, putamen, basal ganglia is the most common site, followed by cerebellar nuclei, followed by thalamus. Okay, so putamen is the most common site of bleed, is the right answer. We can't give antiplatelet or platelet transfusion in the patient who is having intracranial bleed, and immediate stabilization of BP to normal range is not indicated because it disturbs the autoregulation, cerebral autoregulation, which is maintaining the blood flow. If we suddenly reduce, so blood flow to the brain will be compromised. So the answer is A. Okay, in a patient with chronic vomiting, which of the following abnormalities is noted? Okay, what happens when there is chronic vomiting, guys? When there is chronic vomiting, there is loss of HCl from stomach, right? And there is volume depletion in the body. Volume depletion. Okay, once there is loss of hydrochloride and volume depletion, it will lead to activation of RAS, there will be increase in aldosterone, which will try to save sodium but lose hydrogen and potassium. So what is going to happen here? Okay, see, what is going to happen here is there will be hypochloremia, there will be hyponatremia because of volume depletion and recurrent vomiting. There will be hypokalemia. This is hypokalemia, guys. Hypokalemia. And then because of aldosterone, there will be excessive loss of hydrogen. There will be metabolic alkalosis. See, in patients of chronic vomiting due to any cause, we get hypokalemic metabolic alkalosis because of RAS activation. This question is also asked in surgery when they give the situation as patient having pyloric stenosis. Somebody who has pyloric stenosis is having gastric outlet obstruction, will have recurrent vomiting and will present with features like this. And the answer to this question is A. Okay. A young male presents with intermittent headache, sweating, palpitations and hypertension. Diagnosis. Okay, see, let's take all these choices one by one. Hypothyroidism can cause hypertension, which can cause headache, but it is not intermittent. Secondly, palpitations and sweating is not a feature of hypothyroidism. There is bradycardia and there is low body temperature. This can occur in hyperthyroidism again, but there are not intermittent headaches due to hypertension, they are continuous. Similarly, in Cushing syndrome. So, all these have hypertension, all the 4 choices given, but only pheochromocytoma is one in which features are intermittent, okay, in nature. And how do we make the diagnosis? We localize the tumor by MIBG scan and CT MRI. FNAC is contraindicated because these tumors are highly vascular, and the specific investigation is 24-hour urinary metanephrine levels, or VMAs we may say, which are the metabolic product. Okay, the answer to this question is C. Okay, what we are seeing here is there is a fever and these are the features. Okay guys, this is interesting. This is a tricky question, but if you pay attention and by presence of mind you can simply solve it. What here you are seeing is, you are seeing retinal hemorrhages and you are seeing some lesions on palms and soles. Now when you look at the choices, caput medusae, splenomegaly, ascites, they are features of cirrhosis of liver, but it does not lead to these findings. Mesenteric lymphadenitis is usually a feature of TB or enteric fever, it can also happen, or lymphomas, right? Now, if the answer was cirrhosis, then we will have multiple choices as correct, caput, splenomegaly, ascites, but then that is not possible. So basically the answer is infective endocarditis, and he is showing us in palms and soles Janeway lesions and retinal hemorrhages, Roth spots here. And so what we are going to find on examination is splenomegaly, and the answer is B, right? And in the question he has given you fever. Cirrhosis patient will not present with fever also, because these choices, I am telling you cirrhosis because ascites and caput medusae are finding in cirrhosis of liver. So the answer is B. What are the features of infective endocarditis? Fever, right? Then there can be hematuria. On examination there can be splenomegaly. On auscultation of heart you will find some new murmurs or change in the characteristic of pre-existing murmurs. Then there are signs of vascular and embolic phenomena. So you can get Roth spots, you can get splinter hemorrhages in nails, you can get ossular nodes on the tips of the fingers, painful, and then you can get Janeway lesions which are papules in palms and soles, macules, painless like they have shown here, right? So the answer to this question is B, guys. A patient with thyroid mass is being planned for surgery. She has episodic hypertension, headache and palpitations. Again, this is episodic intermittent. In one question we already discussed that this is suggestive of pheochromocytoma. Pheochromocytoma, thyroid mass. Another important thing is mother had renal calculi, that is hypercalcemia, causing renal calculi prior to thyroid surgery. So what is this? See, he is giving us a mix of conditions. So he is giving us thyroid mass, that means thyroid malignancy, mostly medullary carcinoma of thyroid, MTC, pheochromocytoma, and hypercalcemia secondary to hyperparathyroidism, parathyroid hyperplasia. Right? So this is what, guys? This is MEN2 syndrome, right? Sipples. This is MEN2 syndrome. And how do we diagnose? By 24-hour VMA or metanephrine levels. B. What is MEN1? Werner's? We get parathyroid hyperplasia with pituitary adenoma and pancreatic tumors. Okay? And this is MEN2. And the answer is B. Okay? There is MEN3 also, in which we get, or MEN2B. Instead of parathyroid hyperplasia, here we are going to get marfanoid habitus and mucosal neuromas. These are all three are MCQ questions: MEN1, MEN2, MEN2B, or 2B is also known as MEN3. Now they talk about MEN4 also, in which there is again absence of parathyroid hyperplasia. There is pituitary tumors along with tumors of reproductive tracts, adrenals and kidneys. Okay. Okay guys, this is an easy one. What we are seeing here is, this is showing us bending of finger and tightening here. This is Dupuytren's contracture, this is jaundice and this is ascites. So this is cirrhosis of liver. Alcoholic liver disease we cannot say. Alcoholic liver disease has a wide spectrum. It can be simply alcoholic hepatitis, it can be cirrhosis, we don't know. But Dupuytren's contracture and this much ascites is a feature of cirrhosis of liver. See, CKD can have ascites, but then other findings will not be possible. CHF may have congestive hepatomegaly and jaundice, but ascites, this much ascites out of proportion and Dupuytren's contracture again are not the features. So the answer to this question is C. What are the common causes of cirrhosis? The common causes of cirrhosis are, we all know, is metabolic due to excessive obesity and fat like NASH, alcohol, we know hepatitis B, hepatitis C, and then sometimes drugs also, hemochromatosis, Wilson's disease, right? So these are the causes of cirrhosis. Another important thing, what are the markers of synthetic function of liver? I can ask you. That is serum albumin levels and PT-INR mainly. Remember, OT-PT are not the markers of liver function, they are the markers of liver injury. They are the enzymes of the liver. When liver is injured, they are released into the circulation. Whereas serum albumin and PT-INR are synthesized in the liver. So they are marker of liver function. Okay. And the first one to fall when liver is damaged is PT-INR, because factor 7 has the lowest half-life. Okay. An alcoholic patient develops gait abnormalities, tremor, confusion and amnesia. This can occur due to. Okay, this is a simple one. Let me give you a mnemonic, guys, about Wernicke's. This is Wernicke's encephalopathy, we all know. And then Korsakoff psychosis, you will not forget, very easy. This is coat. Coat is, this is confusion. O is ophthalmoplegia and A is ataxia. And T is for thiamine deficiency. Okay. Wernicke's wears coat from Korsakoff's rack. So you will not forget it. Rack is what? Retrograde memory loss. A is antegrade memory loss. C is confabulation, guys. and K is Korsakoff psychosis. This is usually acute, this is chronic, Korsakoff. This is acute, this is chronic. So we know patient is having gait abnormalities, ataxia, confusion. So this occurs due to deficiency of thiamine. Okay. So the answer is A to this question. Okay. In a patient presenting with arthritis of hand, the following findings, what we are seeing here is a soft tissue swelling. See, joint is this, but the soft tissue below the joint, look at this, this is all swollen. This is dactylitis or sausage shaped finger. Okay. So, classically this is seen in, let me tell you few causes of dactylitis. Psoriasis is a very common cause. It occurs in reactive also, but to lesser extent. It occurs in gout also. It occurs in sarcoidosis and sickle cell anemia. So these are the common causes. So the answer is C for dactylitis or sausage shaped fingers. You should be able to figure out by looking at the image that he is not showing arthritis. There is not PIP or DIP involvement. It is a soft tissue involvement, and the fingers have become sausage shaped, right? Because the whole digit gets swollen. Okay. A 30-year-old female presents with cough and following chest X-ray findings. Serum calcium and AC levels are elevated. Diagnosis. Okay. What we are seeing here is bilateral hilar lymphadenopathy on chest X-ray. See this and this, right? It is a young female. Patient has serum calcium and ACE level elevated. It is very simple. It can't get simpler than this, that this is sarcoidosis. Let me tell you a few things which are important from exam point of view and MCQ point of view in sarcoidosis. That it affects pulmonary parenchyma causing ILD, pulmonary fibrosis. Pleural effusion is uncommon and cavitation is rare. This is important. Okay. The findings of BAL are important. It shows increased in lymphocytes. Also, CD4 to CD8 ratio in BAL is more than 3.5. CT is used for diagnosis, where we see pulmonary fibrosis, hilar lymphadenopathy, and also gallium scan will show panda sign. Panda sign is like there is increased uptake in the region of glands. Okay, so there is panda sign. What is basically sarcoidosis? It is a granulomatous, non-caseous. In TB we get caseating granuloma, in sarcoidosis we get non-caseating granuloma, granulomatous disease. Okay, so the answer is B, sarcoidosis. Okay, in a patient of HIV presenting with 2 weeks of cough and fever, presumptive TB is being considered. See, let me tell you something. Have a look here. A patient, this is an algorithm. Okay. If patient is having presumptive TB, for any patient we usually go for sputum examination and we go for chest X-ray, right? Based on these, our patient can fall in 3 categories. Sputum positive is confirmed, right? TB. Sputum negative but chest X-ray positive is suspicious TB. And if both are negative, but if we have high clinical index of suspicion, okay guys, you can see it. I have written it here. See, if sputum is positive, it is confirmed TB. If sputum is negative and chest X-ray is suggestive of TB, we still have suspicion. If both are negative and we have still clinical suspicion, in these two cases we are going to do CB-NAT of sputum or any other fluid if it is available, like pleural effusion or something. But in a patient who is having HIV, we directly go to CB-NAT. If there is presumptive TB in an HIV patient, we skip these steps and we can directly go for CB-NAT. So the answer to this question is A, CB-NAT. Okay. Following laparoscopic fundoplication, patient develops mild pneumothorax. Vitals are stable. Okay. See, this is a secondary pneumothorax, not primary. Primary is spontaneous when it is iatrogenic. So this is secondary pneumothorax. Secondary pneumothorax management is divided into three parts. If it is less than 25%, that means less than 2 cm. Then 25 to 50%, between 2 to 3 cm. Then more than 50% or more than 3 cm. Okay. Here we give supplemental oxygen and observe. We don't send patient home for secondary pneumothorax. Primary we can send these patients home. Here we are going to do needle aspiration, and here we are going to put ICD, drain, intercostal drain, in second intercostal space in mid-clavicular line. Okay. So our patient is having mild pneumothorax, means this one. Vitals are stable, so we are going to wait and watch. So the answer is A, guys. Okay. So I think it is clear. Less than 2 cm, less than 25% or mild, we give only oxygen and we observe. 25 to 50%, between 2 to 3 cm, we do needle aspiration, and more than 50% and more than 3 cm, we put intercostal drain. Which among the following is an indication for artificial pacemaker? Pacemaker, the word itself says where we need pacing. We need to speed up the heart, right? Pacemakers are given in heart, put in heart. So it is usually done when heart is not able to make up the normal pace, usually for bradycardias. Okay. So the common indications are sinus node dysfunctions. Let me tell you few common indications. You can write sinus node dysfunction. Then high degree AV block. We know that AV blocks are of 3 degrees, 1, 2 and 3. Type 2 is again Mobitz type 1 and Mobitz type 2. So high degree is Mobitz type 2 and complete heart block. Mobitz 2 and complete heart block. Okay. Then chronic bifascicular block. HOCM also, hypertrophic obstructive cardiomyopathy, and also hypersensitive carotid sinus syndrome, where there is history of syncopes. Okay. So these are the common indications. So marked by saying marked AV nodal delay, he is probably trying to say high degree AV block. Atrial fibrillation, SVT are not the indication of, the rate is already high for pacing. Post MI, if there is block, especially in inferior wall MI, there is usually heart block, then we may need to do pacing. So the answer is D. Okay guys, this is a simple one. What we are seeing here is this rounded structure, whitish, this is a metallic prosthetic mitral valve basically. Aortic valve will be seen somewhere here. Okay. Native valves are not seen. Pericardial calcification will not seem like a ring in the center. And aortic valve, this is the location. This is a simple question and the answer to this question is D. A patient has multiple episodes of diarrhea with vomiting for past 2 days. He now presents with decreased urine output. Which of the following is likely to be present? Okay, the patient is having diarrhea and vomiting, right? Diarrhea and vomiting means reduced intravascular volume. which means leading to decreased urine output and pre-renal AKI. What happens is when body is losing water and electrolytes, the kidneys try to hold on to sodium and water as much as possible and make less urine, which is manifested as pre-renal AKI. So usually kidneys will conserve, reabsorb all the sodium and water possible. So there is urinary sodium will be low, less than 20. Fractional excretion of sodium will be FeNA, less than 1%. And plasma burn to serum creatinine is more than 20, because urea shows dehydration. So there is dehydration. So plasma blood urea nitrogen to creatinine ratio is more than 20, and urine is highly osmolar. The specific the osmolarity is of urine is more than usually 500 milliosmoles, right? And kidneys will be normal in size and echo texture on ultrasound in these cases. So urinary sodium is less than 20, not more than 40. There is no chance of acute GN. So the answer is C, hyperosmolar urine. Okay. Okay, let's look at this. See, this is a flow volume loop. We do it as a part of pulmonary function test, guys. What happens is, this is a residual volume. This is inspiration. So when we start to inspire, obviously we start from residual volume and we go to TLC, total lung capacity. And once the air is filled to total lung capacity, we again expire and we come back to residual volume, right? So we should understand this. So here on x-axis we are seeing the volume, and on y-axis there is a flow rate. How fast, the rate of flow of air. Okay. So the peak on the expiration side is PEFR, peak expiratory flow rate. Okay. So the normal loop, let me tell you, is somewhat like Joker. This is a Joker's cap. Okay, clown's face. So what happens in obstruction is obstructive lung diseases, the peak, the PFR is going to reduce, this will be low, and there is concavity here. This is what we are going to get. The inspiratory side is usually normal. This is what has happened. This has become concave and this has, PFR has reduced from normal. So this is obstructive lung disease. We know that their obstruction is mainly expiratory because there is no negative intrathoracic pressure to keep the airways open. So obstructions usually manifest in expiration. Normal is like this, and in restrictive, the shape will stay normal like this, the way it was, but the size will decrease. It will become smaller. This will also become smaller and this will also become smaller in restrictive. So the answer is B, obstructive. Okay. Okay, what we are seeing, there is a young woman and we see these changes triggered by cold or emotional stress. They usually affect the fingers and toes along with numbness and pains in the affected areas. There is no underlying illness or comorbidity. Comment on diagnosis. Okay, see, he has clearly told you that it is precipitated by cold or stress, and we can see there is cyanosis and there is pallor in this and there is redness and cyanosis here. So this is how it goes. WBR formed by whitening, pale, then blue, and then they become red finally. Okay, and this occurs in Reynolds phenomena. This is known as Reynolds phenomena. But important thing to understand is the Reynolds can be primary and secondary. Primary Reynolds is not associated with any disease like scleroderma or rheumatoid arthritis or anything, and it is symmetrical. Okay, whereas secondary Reynolds is usually secondary to connective tissue disorders, and also it is asymmetrical. And when we do capilloscopy, examination of capillaries of the hands, in primary Reynolds it is normal, whereas in secondary Reynolds capilloscopy is abnormal. Okay, And autoantibodies are also absent in primary Reynolds. Obviously, when there are no diseases, they are going to be absent, and in secondary, they are going to be positive. And they've written that there is no underlying illness and comorbidity. So the answer is A, primary Reynolds phenomena. Okay. What we are seeing here is a urine output of less than 0.4 ml per kg per hour for past 14 hours. What is the KDIGO staging? Okay, what is the definition of AKI according to KDIGO? AKI definition. Okay, it is rise in serum creatinine by 0.3 or more in 48 hours or 1.5 times baseline. In 7 days, or urine output less than 0.5 ml per kg per hour for at least 6 hours. Okay, any of these three is AKI. If suppose you know that the creatinine of the patient 2 days back was 1 and now it has become 1.4, so the rise is 0.3, more than 0.3, so it is AKI. If it in last 7 days, before 7 days it was suppose 0.7 and it has become more than 1.5 times of that value, again it is AKI. This is all OR. You don't need all these, any of these, or urine output less than this. Then there is a staging based on urine output. If this urine output continues to be less than 5 ml per kg per hour for 12 hours, it became stage 2, and if it becomes less than 0.3 for 24 hours, it becomes stage 3. So now let's see, it is 0.4, so and 14 hours, so for 12 hours, more than 12 hours and less than 0.5 ml. So it is stage, this is stage 1, this is stage 2, this is stage 3. So this is stage 2 AKI. So the answer is B. Okay guys, are you getting my point? Suppose if the urine output falls to less than 0.5 ml per kg per hour for 6 hours. From 6 hours to up to 12 hours, we will call it stage 1. If it persists beyond 12 hours, we will call it stage 2. If the output becomes less than 0.3 for 24 hours, then we will call it stage 3. So our patient is fitting into stage 2 in the given question. Okay, fluorosis of bones is commonly associated with. Okay, see what happens is excessive fluoride gets deposited in the bones and causes hardening of the bones, which leads to osteosclerosis. What is the meaning of osteosclerosis? Increased density of bones. Okay. These sclerotic bones, they are hard and they are brittle. They have less elasticity. So they are brittle. They are increased risk of fractures basically. Ligaments and cartilage may also become ossified in these cases. Okay, osteomalacia is due to vitamin deficiency. Osteopetrosis is a different disease totally, and osteochondrosis is calcification of cartilage. So fluorosis of bones, the answer is A, osteosclerosis. Okay, what is this? This is easy one. If you have worked in your OPD and wards and seen your patients taking inhalers, we know. See, we put a capsule here and we rotate this device, the capsule breaks and the powder comes and the patient inhales basically. This is a dry powder inhaler. Okay. Meter dose inhaler we know, the pressing pumps that we need, nebulizer we know, peak flow meter has marks where we check peak flow. So this is a simple one. So the answer to this question is A, dry powder inhaler. Usually dry powder inhalers are used for TOVA, that is tiotropium bromide. Okay. In a chronic alcoholic, after 48 hours of completely stopping alcohol intake, he develops tremor, visual hallucinations, tachycardia and disorientation. Okay, see, this is after 48 hours an alcohol withdrawal. This is delirium tremens. The prerequisite is it should happen after 48 hours for delirium tremens. Delirium tremens is the most common and most severe form of alcohol withdrawal syndrome, where there is sympathetic overdrive which can cause tremors, tachycardia, hallucination, disorientation, and even cardiovascular collapse. Okay, the hallucinations and all are part of this. Not alcohol aversion is not going to present like this, or anxiety. Okay. Secondly, the treatment is thiamine and benzodiazepine and supportive treatment. So the answer is A. The important hallmark is profound global confusion in these patients. Okay. Okay. This is an interesting question. Child since birth has drooping of upper eyelid except while drinking and eating. Okay, there is drooping of upper eyelid except while eating and drinking. This cannot be cerebral palsy. Cerebral palsy is increased tone in limbs and usually seen after birth, not like ptosis. Facial palsy will not present like this. It causes deviation of angle of mouth, right? And opening, Bell's phenomena. Fourth nerve palsy also not like this. See, this is neurogenic ptosis. This is also known as Marcus Gunn jaw winking phenomena. The mechanism for this is not clear, but what happens is there is usually unilateral ptosis, but whenever there is movement of jaw, because of aberrant connection, the eye becomes wide. The ptosis disappears and eye becomes wider. So that is why there is except while drinking and eating. Okay. So this happens, there is no clear mechanism. Some types of facial nerve injury can lead to this, but this is neurogenic ptosis or Marcus Gunn jaw winking phenomena, and the answer is C. During physical examination of a male intellectual disability, following findings are found: long face, large testes with CGG repeat by PCR testing. Okay, so this is the triple repeat disorder. Okay, and there is CGG repeat, and there is disability, intellectual disability. If I look at all these, Downs is trisomy, chromosome 21, Klinefelter is XXY, Turner is XO. So none of these are CGG repeat expansion. So they have given very easy choices which can give you the answer. So let me tell you something about Fragile X syndrome. The answer is Fragile X syndrome. It is X-linked dominant. There is expansion of CGG repeats and intellectual disability. Characteristics usually are long face, large ears, large testes, flat feet. Okay, these are the features, and the muscle tone is also low, which they have not given in the question. So the answer to this question is D. Okay. In a patient presenting with fever, difficulty in swallowing and white patch in throat, swab was taken and stained with Albert stain. This is also a microbiology question. What we are seeing is here is a rod-shaped bacteria, so bacilli, and what we are seeing is spores at the end, so terminal spores. Bacilli with terminal spore and Albert stain. It becomes very easy. So this is diphtheria. With this information you add clinical picture, difficulty in swallowing and white patch, so it becomes very clear the answer is diphtheria, right? The answer is A. Infectious mononucleosis does not present like this. We know that there is lymphadenopathy, there is fever, and it is viral infection. You will not get picture like this. Measles again is a viral infection. Staph does not present with white patch in the throat and fever, and it is a cocci, it is not a bacilli, right? So the answer is A. Okay. See, you have a patient of cardiac arrest and no pulse. What are you going to do next? This is important. This is just one dictum which you should know and understand. Whenever you find a patient of cardiac arrest, you have to have, you start BLS, basic life support of CPR, where you do chin up and you clear the airway and you give 30:2 compression and breathings. 30:2 is the rate. Okay. After that you should have ECG. In ECG you will find one of the two things. There will be no activity like this straight line, that this is known as pulseless asystole, cardiac arrest with asystole. Another will be ventricular fibrillation, where you will get baseline fibrillatory waves like this. Okay. So the difference between these two, after doing BLS you have to do, you have to give 30:2 chest compression. In this you are going to defibrillate, you are going to shock. There is rhythm, you can defibrillate, you can stop the fibrillation, but in this asystole there is nothing to fibrillate, so you have to give epinephrine or adrenaline basically. That is the difference. You will continue the CPR, you will do everything else, but there is no role of defibrillation in the patients, there is no tracing on the ECG. Okay, so the answer is B, adrenaline. (29) Water lily sign on USG of liver is noted in which of the following conditions? Okay, see what happens is when there is hydrated cyst in the liver which is caused by Echinococcus granulosus. When it ruptures into the lung from the liver, suppose this is lung on the right side and this is liver. So when it ruptures into the lung, it gives rise to water lily sign. Okay. Let me tell you another question which is usually asked is treatment of choice. Treatment of choice is albendazole or mebendazole followed by percutaneous aspiration of the cyst. But if the cyst is communicating with biliary tree, then we have to do surgical removal. Surgical removal if cyst is communicating with biliary tree. Okay guys, so the answer to this question is D, this is hydrated cyst. A chronic alcoholic patient presents with bleeding gums and perifollicular hemorrhages. Which of the following level should be checked for? See, this is interesting. Why? Because in alcoholic patient there is thrombocytopenia because of portal hypertension. There is vitamin K deficiency also. But the perifollicular hemorrhages that occur because of weakness of capillary walls, because of deficient collagen, is characteristic of vitamin C deficiency. This is characteristic of vitamin C deficiency. Okay. Bleeding gums can occur in thrombocytopenia also, vitamin K deficiency also, but these perifollicular hemorrhages are characteristic of ascorbic acid. So the answer is B. What happens is ascorbic acid is responsible for collagen formation. The deficiency leads to fragile vascular walls which presents with perifollicular hemorrhages. A patient with color blindness, presents with color blindness, maternal uncle has similar problem. See, one thing he is telling you, uncle had, mother didn't have. So basically mother is just a carrier. Okay. So for a carrier it has to be recessive and it has to be X-linked. So basically color blindness is of two types. One is X-linked recessive, which is red-green color blindness. Another one is autosomal dominant, which is blue-yellow color blindness. In this case, see, suppose these were the parents, original parents, okay, and now suppose mother was carrier, this mother was carrier, she was carrying this color blindness gene and the father was normal. Of these, the son got this, so he became so the maternal uncle, this he is carrying so the uncle is carrying this gene, so he is having the disease, whereas mother will be one normal, since it is recessive, and one carrier gene. So mother will not be having disease, mother will be carrier. This is what has happened. The uncle has the disease, and now the patient who will get mother's chromosome, X chromosome, will again get the disease. So this is X-linked recessive. So the answer is C. Okay. Guys, what we are seeing here? We are seeing here is DLT, double lumen endotracheal tube. Okay, this double lumen endotracheal tube has two lumens which are parallel, like this. One stops in trachea, the other one can go to right side or the left side as desired. So why do we need double lumen? When we have to operate on one lung and we need to separate the two lungs from each other. Now suppose this is the lung which is getting operated. So this is also getting ventilated through this, and we can do suction and operate, and this we have separated, and this is getting ventilated through this second lumen. So that is the function of double lumen endotracheal tube, to separate two lungs in surgical procedures. So there are two lumens parallel. One is the shorter one which stays in trachea, another one can be put into right or left side depending upon the requirement, and the lung which is ventilated is known as the dependent lung, okay, or non-operative lung. So the answer is C. Okay, this is easy, guys. We have all worked in wards. We know that they have put the hand in the center and they are abdomen, and they are checking for fluid thrill. Shifting dullness, we percuss, we go from side to side, and then we shift the patient to another side, and we see the resonant point has become dull or not. Bloatability is checked in the structure from up and below by pushing from below. Guarding is checked when we put our hand and patient winces and the hand comes up. So the answer is A, fluid thrill. Fluid thrill is a sign of massive ascites. When there is a massive ascites in the abdomen, then we are going to get fluid thrill. For shifting dullness, we need 1500 ml of fluid in the peritoneal cavity. Okay, so the answer is A. Okay, interpret the following serology findings: IgG, NT-HBC plus HBsAg plus. Okay, see, HBsAg plus means that patient is having hepatitis B. If it was acute hepatitis, we will have IgM anti-HBC positive. In acute, we will have IgM anti-HBC. In recent, we will have IgG anti-HBC. In chronic, even IgG will disappear. Okay, only HBsAg will be there. And in recovery, we will not find HBsAg antigen, we will find HBs anti-HBs antibodies. Okay, so the answer will be B, recent hepatitis B. In vitamin D resistance, which of the following occurs? Okay, C, they are X-linked dominant rickets, also known as hypophosphatemic rickets. Let me tell you the pathophysiology. There is reduced reabsorption of phosphate from PCT in kidney. That is the basic defect from PCT, because of which there is increased excretion and decreased serum phosphate levels. If phosphate is low, what it is going to do? It is going to decrease PTH levels, because increased phosphate will increase PTH. PTH causes excretion of phosphate. Once there is low PTH, PTH is responsible for activation of vitamin D. This will not happen, so there is decreased absorption of calcium from intestines. So there is decreased calcium, there is decreased phosphorus, but there can be no response to vitamin D. Even if we give vitamin D, it will not get activated. Calcitriol may help. If we give activated vitamin D, it may help to some extent, but there is normally vitamin D resistance because phosphate is not reabsorbed from the kidney. That is the main pathology. Calcium reabsorption is not a problem. Both, so that is why this is also not the answer, and this is a normal mechanism. So this is also not the answer. So the answer to this question would be A, right? Okay, thank you guys and all the best. Study hard.